Hi, everybody. We decided to do this because I'm too tall for these. And as you all know, I'm prone to do this a lot, right? But I'm going to try to stay right here so I can keep my eye on Melissa and my time. And hopefully keep us on schedule. That's my goal, absolutely. But we need to actually all stop and say thank you to, Lila, Angela, Melissa, Andrew, and George, because if it wasn't for their continual efforts, none of us would be here. So thank you. So my task is relatively simple. You received a copy of the commission paper in one way or the other that we were commissioned to create, and I get 15 minutes to convince you to actually read it, if you haven't already. And if you had, then I get to convince you to change your mind and really like it. But we've heard some great response. Thank you for those. This would not have happened without these other three individuals, Jennifer Cabe and R.V. Reichard, right here with this, but also Lori Martin, who you heard referenced. We're all co-authors on this, and I'm just fortunate and blessed to be able to work with you all, so thank you. And also, right, the people who you're going to hear from, the case studies, and the many people who were too much to list who actually made this possible. We did 3 case studies in this, and you're going to hear from them directly, so I'm not going to talk about them. But it's probably worth saying that if we'd have done 6 case studies, we'd have been hard-pressed to find appropriate examples. We found 3 stellar examples. I would not call them representative of the field of public health. I would call them best practices that currently exist within the field, but what they're doing needs to be spread far and wide. Our focus was on state, local, tribal, and territorial public health organizations. We tried valiantly to identify an explicit effort within a Native American community that was conducted by the official public health organization responsible for that community, and I failed. That does not mean that it's not out there, but we couldn't find it. We also did a very direct question to each state's public health department, and we just use their primary contact information for that they give to the general public. If you have a question, use this phone number or email address, as the case may be. And then we did an online survey of public health department employees using a wide variety of electronic listservs and mass communication, as well as direct contact to numerous individuals. In fact, every person who's a member of the American Public Health Association who is listed as working at a public health department was sent multiple direct inquiries to respond to this survey. So we actually reached thousands of potential people, and you'll see the response that we got as we go forward. If you want to learn more about the methodology, read the paper. I'm not going to spend 15 minutes to talk about that. That's it right here. So, the question and sort of foreshadowing conclusion is, right, is health literacy still missing in public health? And, following the last 2 speakers is not the easiest thing to do. Maybe you guys should have gone last. We could have built up to that instead of open with the sort of grand crescendo. But I'm sure the rest of the day is going to be great, too. To those of you who are coming, I'm trying to lower the bar now instead of raise the bar. So, but in this process, we were given pause to think back to, if there's one story that every student of public health ever hears, it's the story of John Snow and the water pump in London. And how that is given credit as the founding of epidemiology and by and large public health is an extension. But I have read that story and looked back in every textbook that I could find briefly. Never was the public depicted as empowered or participants in that process, other than they were mainly depicted as hapless victims. That public health could come along and do a top-down technological solution and the world would be better as a result. And I think public health as an institution needs to sort of go back and question that original founding story or founding myth, as the case may be, because try as I might, I cannot imagine how he actually accomplished that without a bunch of engaged people telling him about their lives and where sickness came from and what they did yesterday and what they thought might be the cause, because it certainly never, ever does a solution arrive in the mind of one person only. So I think if public health could just re-question that fundamental assumption, we would, in health literacy, be great beneficiaries. And of course, Rima made the point about workforce training, so this leads right to that. How are we training the workforce in public health from a health literacy perspective? I think it's a place there's a lot of gains to be made. When we contacted each state Department of Public Health directly via what they tell people to contact us through phone or email in every case, this is the response we got. Every state that's in white did not respond at all, in no way, shape, or form, and we contacted each one at least 3 times. And we still never got a response to a very, very simple, single question, right? That was it. We asked one question of them, and we still didn't get a response. You will hear from Arkansas later, and you will notice that Arkansas is the only organization that reported having a staff member within the Department of Public Health whose explicit title included the phrase health literacy. Now, that doesn't mean other departments aren't addressing health literacy, but speaking as someone whose title is Senior Director for Health Literacy and Research, it does make a difference. And we've seen numbers of people with health literacy in their title grow over the last 10 years. So I take it as an indicator of interest and activity. You know, a number of states reported that we have no formal health literacy efforts ongoing. You can read into the white states however you want to, because we, of course, got no response from them. A number said that it's part of our work, and a number also said that it's a part of our work, and there's a specific point of contact within the organization, even though it might not be in their title. So you can see that some areas of the United States are poorly covered, some are well covered, but there's a lot of missing gaps in what's reported. So that led us to say, well, we need to do more information gathering, so we created an online survey via SurveyMonkey and distributed, as I said, far and wide. So we had 63 responses to this online survey, which sounds disparagingly low. And at first, I will admit, we were terribly depressed, but then we actually started looking at who responded, who were those 61 people, and who do they represent? And it turned the picture around quite a bit, at least in my mind. The average population of the organizations that responded was over 3 million people, and when you added them all up, they represented a population of over 95 million, about 1/3 of the US population. Which says, well, it was a small but perhaps powerful and appropriate group of people to inquire about. And on average, the people responded had a little over 16 years of experience within the field. So it wasn't, you know, people right out of college in their first job. They had moved into middle and upper management positions. We did collect personal information, so I do know who each and every one of these people are, but I'm not going to tell you. A very small number of them, actually, 7 out of the over 60 reported using the IOM's definition. Well, I found that surprising. The larger part, over half, said that they used one of several definitions. 12 said that they did not have a preferred definition of public health, and a couple said that they're in the process of making it happen for them now, but they felt the need to create their own. This is, you know, a classic question in the history of health literacy. Where does the problem lie? So we asked this as well, and I think we'll all agree that this is lovely, that the vast majority of people saw it as a two-sided issue, which is a relatively new development, really, within the field, but it seems to have been adopted by those individuals already. Because, right, the Roundtable just sponsored the development of the attributes of a health literacy organization, we figured, well, let's just see, let's ask. So we did this as simply as possible. We took the attributes as you, the co-authors here, wrote them without editing and put a Likert scale at the end of it and said, tell us, what do you think? So here's the response. And anything on the average response over a 2.5 says that more people agreed that that statement reflected their concerns and activities than disagreed. And as you can see from the first 5 here, everybody was more in agreement that this was part of their mission than in disagreement. We also asked, though, a very yes-no question, is this relevant to what you do? And you see the third one, prepares the workforce to be health literate and monitors prognosis. A couple people said, no, that's not relevant to our mission in public health, much to my surprise, but it is what they said. And as we go to the second 5 of the attributes, you'll see that as we move down, these are actually ranked in, not in order of preference, but by relevance more or less. The last two, which really focus on clinical settings, care transitions, and health plans, were the most irrelevant, but yet still more people agreed that they fell within the larger mission of public health than disagreed. So from that perspective, I say the attributes seem to be appropriate to a public health context as well as the clinical and medical contexts, which by and large they were sort of extracted from. So we asked, what are you doing in health literacy? And on this was a slightly different scale. It was just a 3-point Likert scale, so anything over than 2 indicates that more people reported they're doing these specific activities than not, and these are listed in order of that response. So rewriting materials and developing an awareness of cultural competencies were the 2 most frequently selected activities that people said they were doing. And then training staff was next, training translators was next, and we keep going. This is a list of health literacy activities, oops, sorry, I've used before, and you should never push that button when you're not ready to push that button. So there we go. As I was saying, rewriting signage and then piloting new materials, that's the end of where most people said, yes, we're doing this versus no, we're not. Using health topics to teach literacy skills fell below what would be the mean, essentially, of the scale. So less people said they were doing this, and adopting an organization-wide plain language policy was the least frequently conducted activity within the public health organizations that responded to the survey. And you know me, I have to say, unfortunately, editorial comments every now and then. So here's just an illustrative quote from one of the participants that I think sums up more or less the overall impression that at least I as an individual received from the responses. I've been frustrated with the approaches and discussion of health literacy in my agency and in general. There seem to be a lot of misconceptions about how it impacts what we do. I think we've all heard this a lot in our careers, right? That people might be aware of it, but they look at the research, they look at what are the quote-unquote best practices, and they just don't see a robust solution for them. So the burden is on us as well to lead this change, and the quote continues, right? Much of the research is contradictory and far removed from public health practice. So while we can certainly see, as Rima eloquently as always described, the connections and the power of health literacy to public health, people in public health don't share that same vision based on what we've told them so far. Seems to be the case. So quickly, we'll just run through the short series of recommendations, right? Develop and implement a locally relevant, specific, measurable action. What is a SMART goal? Do a SMART goal, right? About how you're gonna do health literacy. This might be one of my favorite ones, other than the last one. Require public health agencies to report on the health literacy status of their populations, and we just saw a way that they could actually do that. But you know what's gonna have to be required is they're gonna be required. They need to be required to do this. It cannot be voluntary. We can create incentives that'll help through lots of ways. Mandate that health literacy is included in all of the programs and curricula that public health agencies develop. Mandate the training through these organizations for credentialing processes that health literacy must be part of public health training. Build a repository of best practices, and make sure that all future public health legislation explicitly focuses on health literacy as an opportunity for public health organizations. Nationwide effort to improve. This is something we've never had. We have done national assessments of literacy, which sometimes include health literacy, but not of late. But we have never had a national literacy campaign in the United States that I'm aware of, whereas other nations have had multiple, and then dropped and adopt health literacy policies within all public health organizations. Now, us as a roundtable, I have one recommendation, which I know is an onerous and scary amount of work, but I believe it's definitely the time. The 10th anniversary of the initial IOM volume is next year in 2014. You can see, using the lovely search tools that the IOM gave us, that in fact public health is poorly represented within and throughout that volume. On a simply superficial level, on a conceptual and content level, those, I know you've all read it many times, so you know exactly what I'm talking about. The focus is on clinical and medical applications of health literacy. Other reasons to do this, right? We've all, for almost 10 years now talked about the problems with the definition put forth. We see that public health agencies are not adopting that definition. They see the problems. They see why it doesn't fit them. So there's another reason. And of course, the last 9.5 years of Advance is actually 10.5 because it was written before it was published. All the work that we've done over the last decade are not represented in that volume. And I think the 10th anniversary is a lovely time to do that. And that's my closing recommendation. I'm probably a minute and a half over, I'm sorry. But thank you very much.